anatomy, physiology, and introduction into the diseases of the skin, whereby we see terminology or terms and the patterns of diseases. And then we'll discuss some specific entities. We will see the changes in pigmentation, epithelial cell tumors, and the dermal tumors. So the skin glands such as the sebaceous glands here, and also you know that we have a sweat gland, but sweat gland are more okay, it is here. It is more seen in the hypodermis. So below the dermis you have a hypodermis, which is just fat, but in it you have also blood vessels, you have sweat glands, and the hairs they arise from hypodermis, and they are associated with sebaceous glands, and the hair, of course, as you know, it must come out from the pores to the surface. So for these hair follicles or hairs themselves to move and so on, we have smooth muscle cells, which are called erector pili muscles. These are important, and actually they have a role. I think mujya mwumvaga umuntu yarakaye umusatsi urahagarara. When they say so, you must understand it even scientifically. Nuko reaction runaka umuntu ashaka kugira, izi muscles zikaba contracted, imisatsi uburyo yaroriente cyangwa se ubwoya bugahindura direction. So ngira ngo iyo bivuga ntabwo ari ugukabya, ni ibintu bishoboka, because these are smooth muscle. Smooth muscle is not controlled by our they are involuntary muscles, so they can be controlled by nervous system when it is stimulated by anything. So all this, the glands and the hairs, these are called the Epidemio Appendages or skin appendages. So what do we have in the epidermis itself? So we have many areas. Starting with the basal part, you know, between the epidermis and the dermis, you have a basement membrane, which just makes sure the epidermis is correctly attached to the dermis. And then we have a cell, epithelial cells. The first layer is called stratum germinativum. And for this one, some they say here we have a stratum basale. Stratum basale meaning the bazar, and then we have a stratum mucosum, and have a stratum granulosum here. These cells are usually brackish. They contain a pigment looking like melanin. Then you have a stratum lucidum that is not seen in all skin or the skin sites, and the stratum corneum, which is basically keratin debris, which will be sloughed off. Okay, so that was a drawing. This is the real picture. This is the dermis here with the collagen fibers here, which are reddish. We have some blue. This blue says these are fibroblasts. Know that fibroblasts are the ones producing collagen. Of course, we have small blood vessels. This is a vessel with its endothelial cell. And then we have, this is a reticular dermis. Here we have a papillary dermis. Normally the papillae, as we know, these parts of the dermis which look like penetrating into the epidermis. These ones are called papillae. Here the dermis is looking like penetrating into the. Then you have epidermis here on the surface. And we have the basement membrane, which is imaginary because you can't see it on routine staining unless you do a periodic acid shift staining. Then we have a stratum basale and the other areas until you have a stratum granulosum. Here we have blackish cells. And then we have a lucidum here. There is a reddish line, which is a cellular, and then you have a corneum, where you have this like looking like basket waves. So in this skin, we don't see melanocytes with their melanin. We don't see them clearly. Melanin is pinkish. Yes?
You're not seeing
We
the
can
cast.
the point.
But don't you see it now?
Point
No.
not being seen.
So we restart then the presentation because for me, I see it. Do you see it now? Okay, don't talk. So,
No, we can't see it.
sorry?
We can't see it.
So what is the problem? Because me, I see it. What will be the problem? Maybe on your side. Okay, on this picture we have a hair here, and I think you can see it clearly. Sorry,
I have a question.
which question? Yes.
You said about the areas of epidermis. That one of stratum lucidum. You said that it doesn't.
I don't hear you. Can you be closer to the microphone?
I'm saying you told us about those layers of the epidermis. That one of stratum lucidum, which is not found on all parts of the body. So I was just asking specifically which parts does this occur?
That question should be answered by you. You have a course of you had a course of histology. Yes or no?
Yes,
Sorry.
yes. We have question about the skin.
Then did you
Maybe by
you learn
answering the
this?
question.
Sorry.
Yes. Yes, you have run it.
Ntabwo mwabyize se?
Barabyize.
None ikibazo ni iki? Iyo mubonye ibintu mutibuka murabibaza cyangwa mureba aho mwabyize. Okay, that one is seen in thick skin. Ubwo nabyo muravuga ko mutazi thick skin aho iri ku mubiri wacu. Okay. So here we have a hair follicle, a hair, and it is surrounded by the sebaceous gland. Yango ni ibintu bisanzwe ko sebaceous gland ikora ibintu bimeze nk'amavuta y'ibyo bisohoka, it lubricates the skin. Ukagira ngo umuntu isize amavuta kandi atayisize. That is one. But also, as you know, we have sweat glands which produce
cursor.
Sorry?
We can't see the cursor. Maybe it's not allowed to be visible for us.
Allowed by who? Because before you are seeing it.
For you, because like if you click left click, then you go to point option. You
Left
go
click
to
or right click?
left click.
Left, right.
Left, then you go point option.
Yes,
allow
I click the right click, pointer option.
Go allow option. Allow option. Down, go to visible again.
So for me, it is automatic. So let's do. Is it now seen?
No.
Because it was automatic. Sorry?
We can't see.
Because for me, it was selected as automatic. Now I say visible, I make it. So now it is hidden, of course.
Yes,
So
now we can see it.
Yeah, we can.
So because I changed it to be, it is still automatic, but not. I made it laser instead of being an arrow. So that is just the difference.
Okay.
So I was saying this is the air, and here we have the sebaceous glands. It is a drawing, of course, and we have this is the dermis again, and we have many other things here. The parts of the hair, we have the bulb, the papilla, the bulb. We have the cortex, and so on. So now, how about the melanocyte? On the histologic image I have shown, I said we don't see melanocyte. Here there is a drawing. The melanocytes are on the basal layer of the epidermis. Here, so here we have a stratum basale, but among the cells we see those which are reddish here. This is a drawing; it is not a true picture. Those which are reddish, and they have processes, cytoplasmic processes penetrating outwards to between epithelial cells here. So these are the melanocytes. They produce melanin. Ariko aho ubona melanin hose nabaye melanocyte, because the melanocyte they will be captured also by other epithelial cells. So as you know, this melanin is very important. It protects us against the effects of ultraviolet light. As you saw in carcinogenesis, that ultraviolet light creates many defects in our DNA. So melanin works as the protection against the effects of ultraviolet light. And of course, there are many types, two types of melanin. The one we have as Africans, and the melanin in those who are not black. But in all, it serves to protect us. Maybe our melanin as Africans is more protective, especially that we live in areas which are more sunny than those of western or eastern parts of the world. So there are the other cells which are called the Merkel cells. It is difficult to know where they are on hematology in the earthen stain. So for us, we use immunohistochemistry to know the Merkel cells. Also, there are types of neuroendocrine cells in the skin, and a carcinoma arising from this, we call it Merkel cell carcinoma. So Merkel cell ni umuntu Merkel ni umuntu wavumbuye sterile bwa mbere. So that's why na carcinoma is ikomoka kumeje kwitwa. So the special stains we used to do, they are NSE means neuron specific anomalies. There is keratin and neurofilament and the others. They are those we use when we want to diagnose this disease. the disease of arising from mercury cells. So as we said, for the skin, it protects, it holds us or the organs together, it regulates water metabolism, because as you know, iyo hanze hashyushye cyane umubiri kugira ngo utinjirwamo n'ubushyuhe bwinshi ugabanya amazi urimo, then you sweat. Iyo hanze hakonje cyane ntabwo umuntu abira ibyuya kubera ko umubiri ugerageza kugumana temperature wirinda gusohora amazi. So the synthesis of vitamin D, you know it, and also it helps us to protect ourselves against injurious agents such as infectious agents, and it is one of the parts of the innate immune system. So common pathological terms. We have acantholysis. Ngira ngo ni terms turagarukaho nyuma gato, ni mpamvu ugomba kuzitaho. Acantholysis, there is word acanthos, it just refers to the layers of the square of the epidermis. So the squamous epithelium. Lysis, it means destruction. So if these cells are destroyed, we'll say there is acantholysis. So there will be loss of intercellular connectors, such as desmosomes between keratinocytes. So therefore, you will see cells separated from one another. So as we shall see in some diseases such as pemphigus, the result will be that if the cells are okay, sorry, I had lost my internet connection. I hope you can hear me.
Yes, we can.
Okay. And you see the screen and the cursor. So I was explaining the issue of acantholysis in diseases such as Pemphigus vulgaris and the others. They created space between epithelial cells. It will be abnormal, of course. Sometimes it will be filled with fluid. Clinically, this will appear disfiguring the person. Uzasanga ari umuntu ufite uruhu rumeze nk'urw'ingwe and so on. It is a very bad, clinically a very bad disease. Ariko ugasanga histologically there are just very small spaces between epithelial cells. So acanthosis, it is a thickening of epidermis. Ariko ijambo ntabwo rikoreshwa kuri epidermis, ushobora gukoreshwa ahantu hose hari squamous epithelium, muri oral cavity, larynx and so on. Whenever there is increase in the thickness of the squamous epithelium. We can say there is a keratosis. There is atrophy, you know it from the general pathology. There is this thinning of epidermis, meaning there is a decrease in the number of cells. Basophilic degeneration, it means some cells will, some structures will be changed. And here, specifically in the skin, we have this problem in the collagen fibers within the dermis. Iyo umuntu yishwe n'izuba cyane agira the collagen, they will be fragmented, but before they are fragmented, they will appear like elastic. Uzasanga ziri coiled like elastic fibers, and they will be blue in color. That's why they say basophilic degeneration. This is seen in patients, not patients, anybody who is exposed to the sun for a long time. Harinu Tari exposed there for a long time, but who have, for example, the syndrome called ectodermal pigmentosome, to have seen in the general pathology in the carcinogenesis. There's these persons, they have problems in protecting themselves against ultraviolet light. Blister, as we saw, it is a vesicle or bure, which it means there is a nodule, something looking like a nodule, which is raised above the surface of the skin, but which is filled with a fluid. So bule is larger than the vesicle itself. So if the vesicle is filled which is filled with a fluid is more than 5 millimeter diameter, then it will be no longer called a vesicle. It is better to call it a bule. So carcinosis, it is not a carcinogenesis. Carcinosis, there is this word, there is L, so it refers to calcium, not to cancer. In cancer, we have R here. So it refers to the deposit of calcium. And these are patients who will come, they have painful nodules around the skin somewhere. You do X-ray, you find it looks like a bone. And when you do biopsy, they will tell you it is just a deposit of calcium. So, hano indwara zaita carcinosis cutis, because if it is in the skin, cutis refers to the skin. So we saw some case, I think, like 4 years ago, we saw a case from the Western province. So they had treated many diseases. I think it is leprosy and so on. And at the end they thought it is a cancer, but when we look at the biopsy, it was just a carcinosis. And in that case, because it is rare, we published it in a local journal, Rwanda Medical Journal. So colloid bodies, also called civet bodies, I think you remember them. We saw them in the lichen planus in the previous presentation. Comedo, hair follicle and epidermis is dilated and plugged off, and it is filled with keratin and debris. Cyst, you know, it is a cavity which is filled usually with fluid, and it has a true epithelial lining. And as I said, when there is no epithelial lining, we call it a pseudocyst. This keratosis, this is abnormal premature keratinization of a keratinocyte below the granular cell layer. You remember where we saw granular cell layer in the epidermis. Normally, the cells below it, towards the basal membrane, should not have keratin. When they become keratinized, we say there is this keratosis. Epidemiosis, usually in this case, you see that also there's the word lysis, it means destruction of some parts of the epidermis. There will be alteration of granular layer with perinuclear clear spaces, swollen and irregular kerato higher in the granules and so on. So epidermotropism ni ijambo dukoresha dushaka kuvuga niba hayeho region ugasanga selile zishaka kwataka epidermis, tuvuga ko hari epidermotropism. Tropism, you know, it is something that refers to attraction. So if a cell is attracted to come to the epidermis, we'll say there's a epidermotropism. So we see it in some cancers, cutaneous T-cell lymphoma usanga when this lymphocyte and any inflammatory cells should not reach the epidermis. They must be where there is a vascularization in the dermis. But when they come above and they infiltrate the epidermis, we say there is epidermotropism towards these cells. So erosion and ulceration, I think we discussed it before, and erosion is more superficial as compared to the ulceration. Excoriation, deep urinary scratch, often self-induced. Exocytosis, you learned this in physiology. Uko serire ifata ibintu bya birimo ikabyohereza hanze, so by a mechanism called endocytosis, exocytosis. So hydropic, it is when you see cells are filled with the fluid, so they will be swollen as compared to the normal ones. Hyperkeratosis, there will be too much keratin formation. Another orthokeratosis. They are so in hyperkeratosis we have orthokeratosis and parakeratosis. So ahanga icyo cyane iki stratum coroneum area niyo tureba. Iyo ari nini cyane as compared to the normal situation, we say there is hyperkeratosis. Now, if we have nuclei within the coronal layer, we say there is parakeratosis. But if there are no nuclei, we say there is orthokeratosis. And these terms are very important because kumurwayi umwe kuri history tukubwiye ko afite orthokeratosis cyangwa parakeratosis, bifite icyo bivuga. Usually the diagnosis will differ and the treatment will differ. So lentiginous is a term that we use about melanocitic proliferation within epidermal basal cell layer. So when there is a proliferation of melanocytes, you saw that, of course, they exist in the basal layer of the epidermis. But when they proliferate and they continue to be just around the basement membrane, we say there is a lentiginous pattern of overgrowth. So lichenification refers to a thick, rough skin with prominent skin markings, markings usually due to repeated rubbing. So, uzasanga ahantu umuntu akunda guhonda, hari umuntu ushobora kugira amabavu, hari abantu wenda bakora basenga wenda bakubita impanga hasi, usanga hari aho hantu. So my internet is not good. So do you see the screen?
Yes, we see.
Okay. So I was explaining this lichenification. So anything when the skin is rough, irango hari ibintu plants mwiza muri secondary bita lichen. Lichen is ni ibintu bimera ku bitare by'amabuye cyane cyane. So uruhu rw'umuntu rwakomeye gutse niyo mpamvu ni hiryo jambo ryavuye lichenification of the skin. So lichenoid interface change. So when we say interface change in the dermatopathology or dermatology, we refers to changes which are at the intersection between the dermis and the epidermis. So akenshi usanga n'ubundi lichen planus mwe twabonye mbere, akenshi usanga inflammatory cells, they are at the junction between epidermis and the dermis. So macule is circumscribed flat colored area of any size. So icyo bivuga ni iki, haba hari uguhinduka k'uruhu ariko ntabwo haba habyimbye cyangwa ngo hatebere habe excavation cyangwa ulceration. So ni ikibazo cya kara gusa yahindutse kuri skin or any mucosa. Nodule, of course, you will feel something which is a mass circumscribed. On corysis, there is a loss of integrity of the nail. Onco here refers to the nail. So rhysis distraction. So papillomatosis, this is when there is upward overgrowth of epidermis with elongation of dermal papillae. So patch, there is a flat discoloration of more than 5 millimeter. Papille, it is the elevated region as compared to the surface, but less than 5 millimeter. Ariko yirenze 5 millimeter, then it will be called a nodule. Ariko nibiri if the flat surface, it will be called the plaque, not a nodule. So these terms, we will learn again them in dermatology because they are important when you describe the regions. So purpura, there is extravasation of red blood cells into the skin. I think this we saw it in when we saw hemodynamic changes. So pistil, it is intradermal or subepidermal vesicle, but which is filled with pus. So sinus is a tract connecting cavities to each other or to the surface. So bava ngo umuntu afite wenda fistile ikorwa n'iki? Fistile bavuga ko harimo sinus. So ugasanga wenda haje communication between let's say the abdominal cavity to the skin. Ugasanga ibintu biva muri abdomen birahita bisohoka hanze. Or there is an abscess somewhere, and then that abscess has created a tube, let's say a tube, which now will, through which the pus will discharge to outside. If we go back to what I said, the fistula, for example, in women, if she has a vagino-rectal fistula, it means there is a direct communication between the vagina and the rectum. And the causes are mainly the traumatism during delivery and so on. So that communication itself will be called the sinus, but the condition or the disease itself will be called the fistula. So spongeosis, it is a term used when the cells are separate each from each other, but not creating a space. We'll see that they are separate, ariko ntizikore space nini nk'izo muri Pemphigus Vulgaris, ukabona kandi biri ahantu henshi amazi hayuzuyemo amazi. So quality spongeosis, ulceration of vesicle, we had explained them before. Where it's itchy, transient elevated area or variable blanching or whitening, and erythema due to dermal edema. So these are some of the terms you will be seeing in dermatopathology and dermatology, and it is important to understand them. So the basic patterns. In dermatopathology and dermatology, usually you reach the diagnosis because you described what you saw, and from the description, then you say this patient is having this pattern. Ni nkuko twabonye handi mu kwejita syndrome. Nangwa umuntu afite malaria syndrome, nuko afite umuriro, afite ibicurane, aribwa umutwe, and then ushobora kuvuga ko umuntu afite malaria syndrome cyangwa se flu syndrome, ibicurane. So hanga muri skin ntabwo ari bakoresha syndrome, but we use the patterns. So what shall pattern nk'abandi umuntu afite inflammation which is lymphocytic and which affects the junction between epidermis and dermis. So icyo rero nshaka kuvuga ko umuntu afite as a pattern, afite lichenoid pattern, because it is inflammation at the junction of dermis and the epidermis. So I will say that this patient has a lichenoid pattern of dermatitis. But that is not the final diagnosis. I will have to go into the differential diagnosis of the lichenoid pattern. So among them, of course, I will have lichen planus, but I have also many others. So I will have to do investigations to rule out some of them and rule in the real diagnosis. So the basic patterns, as I was explaining, what you see if there is interplay between epidermis and dermis. You see if there is a rash kuri munagira amaheri menshi kuri uduheri, and reddening it is red. Changes in the pigmentation, shape, and of isolated regions. Are they macule? Are they papules? Are they vesicles, pustules, and so on? Or these are important. So, for example, this one is having inflammatory dermatosis. It is not a diagnosis itself. It is a pattern. Inflammatory dermatosis. So, as you see on the skin, you can describe. You shall put a macule because it is reddish. So it has changed the color. Ushobora kwita erythema ni change of color. The skin changed its color to become red. So these lesions are reddish. Probably they are not raised because for that you have to see it live. You have to palpate to know if there are nodules inside or not. So if you don't feel it or this, you will conclude that there are macules, which are red. And then you will continue to describe there are many bilateral, and depending on the circumstances. Then you will have a final diagnosis. So in inflammatory dermatosis, we can have urticaria. Urticaria means there is a this is a term which is used. Urticaria. They are generalized. They may be due to allergic reactions. For example, or it was caused by medications. So meaning that you have to ask for this information during history taking. Some are mediated by immunoglobulin E, and as you know, this participates in allergic reactions because it causes the release of histamine, causing vascular dilation, or this you have seen in acute inflammation, and fluid in tissues or edema. So, kuba ko umuntu afite urticaria, it is a clinical description. So, what do you see on histology? Here you have epidermis, and corneum there. So, what do we see in dermis? We have some vessels here. They seem to be filled by something which is not blood. Here we have a collagen fibers, but between collagen fibers you have a whitish component. This is water, so there is edema. So here you can confirm that edema. Then you have a few inflammatory cells around. Hari ibyo bita eczema mu Kinyarwanda ntabwo byoroshye kubona icyo wabijyanye nabyo, ni nk'ibyo bitaga ibinyoro kera bitakiboneka. Nta n'umuntu kugira ngo murabona how the skin is, ni bitaga ibinyoro mu Kinyarwanda. So nowadays there are rare diseases to see. So what do we see on histology? You remember what we saw as the normal histology of the epidemics. Ariko hano murabona ko muri epidemics hajemo Ebola, which is filled with a pinkish material. So we don't have squamous epithelial cells here, but there is a cavity filled with a fluid. So it is this that clinically we describe as a vesicle. So contact dermatitis, how does it appear? This is like a pathophysiology of it. So hari ikintu wahuye nacyo agency here. Then some of the antigens from it will be captured by our dendritic cells that have dendritic cells in epidermis, in the skin, in the mucosa, and so on. These are like macrophages. They will capture antigens, and then they will, when these dendritic cells travel through the lymphatics, they will arrive in the lymph node, and when they arrive into the lymph node, they will now target them, telling them this is the antigen we captured, it is like an enemy, so find a way you will fight them. So there will be now a challenge. Challenge is what? Is when the lymphocyte will leave the vessel and they go to that area to kill these agents from which the antigens were presented. So I think these are principles in the course of immunology. So erythema multiforme, erythema, as I said, it is a term used when there is a discoloration of the skin to become red. So there will be red macule. Macule, you remember, is just a change in color. There is no depression. There is no raising above the surface of the skin. So red macule with the darker center. So the center of each macule is dark as compared to the periphery of that macule. Usually this is caused by immunological reaction, meaning that there is allergy to something, either by contact to something or something you have eaten or injected in yourself. There will be lymphocytes in the dermis, as we see on the right side here. Many lymphocytes, this black dot, they are nuclei of the lymphocyte. So the chronic inflammatory dermatosis, they are of course a persistent chronic. The epithelial reactions are characterized by increased turnover rate. Mouth thickening, scarring, roughening. It will be not smooth. You will feel something hard in the skin. The inflammation will be variable within the dermis. So among them, hereditary psoriasis, it is frequently seen. I remember that when we are in the first year of fourth year of medicine or fifth year, there was a colleague student. She was a student in biology, I think, at the university. She developed this. Okay, maybe because I knew her, she was from history. So she developed psoriasis, and it is a difficult disease to treat. So you see how it appears, and unfortunately, right, also normal mistakes. Bimeze gutya harimo ibintu bimeze gutya bivuka imisatsi ikavaho and so on. So ni so it is thought that it is caused by a real immunological reaction between antibodies and some antigens, which are not yet described. Bikunda kugaragara kuri knees, elbows, scalp cyangwa mu mutwe, glands. The whole body is pretty bad, and at areas of trauma usually niho biba exacerbated. So bakayiteta salmon skin cyangwa n'ifi yitwa kuri ababyitiriye. Umuntu afite ibintu bimeze nk'amagaragamba y'ifi. So on histology, what do we see? We see acanthosis. You remember acanthosis is thickening of the epidermis. Long rete ridges. Ututuntu twa epidermis iyo tumanutse hasi muri dermis nitwo bita rete ridges. Naho dermis izamutse muri epidermis nibyo twita dermopapilli. So dermopapilli, they are parts of the dermis coming upward into the epidermis, while rete ridges, they are parts of the epidermis going down to the dermis. So other things, they are the thickened granulosa layer, stratum granulosum. So microscopic abscesses in epidermis are a little bit Munro abscess and so on. Kogoch abscess. So nibyo nibyo tura kuri histology. So lichen planus twavuzeho kare kuri muri oral cavity. Again we come back on it. As I said, in this disease we have interface dermatitis, meaning there is inflammation at the junction between epidermis and the dermis. So clinically nuko bimeze ni ufite uruhu agashe cyangwa rukomeye nka cyatsi niyo bitari. So, and there is Lupus Erythematosis. I think I mentioned it somewhere in the previous presentations. Systemic Lupus Erythematosis ubundi ni indwara iterwa na ikibazo cya muzi ko iyo serire ipfa ishobora gupfa by apoptosis or necrosis. Iyo serire ipfuye by apoptosis, the cell will be fragmented into apoptotic bodies. Each body will be surrounded by a membrane, let's say so. And thus, no leakage of cellular content will happen. Here, habaye ikosa hariho leakage that of these cellular contents when the cell dies. The body will react to this because they should not appear extracellular. So when the body reacts in different areas to DNA of dead cells, the disease resulting from that phenomenon will be called systemic lupus erythematosis. So the disease manifests itself through different organs. Ariko aho bikunda kugaragara ni ku ruhu, mu mpyiko cyane cyane nabyo byica abantu. So therefore is the autoimmune nkuko mubyumva, the body will form antibodies to destroy its own cellular components. It can be systemic if it affects many organs, or discoid if it affects only the skin. So you see this person how she has parts of her face reddened. So systemic problems will cause kidney failure, vascularitis, and deep venous thrombosis with embolism. Antibodies in its serum, which will be measured, are anti-DNA antibodies. Nkuko nabivuze umubiri uri kureactinga kuri DNA of the dead cells of that same person. So what we see in the skin, in this case, there are chronic inflammation. It is lichenoid because it affects the junction between the epidermis and the dermis. And you can see antibodies at the dermo-epidermal junction. Antibodies as one, you must do special stain, immunohistochemistry or immunofluorescence. So here they have done immunofluorescence in situ. So aho ubona habaye more bright, it is where it is positive. Nuko kwanga hari anti-human immunoglobulin that came to destroy this part, and you see it is at the junction of the epidermis and the dermis. So immunofluorescence in our country is not routinely done. At the King First Hospital, they have possibilities to do it, but they practically don't do it. In the other hospitals, we are trying to implement it, but not yet. But it is very helpful in dermatopathology and in the kidney pathology. So acne, abantu bagira amaheri mu maso and so on. So it is usually called acne vulgaris. It is mostly seen in the males and thought to be caused by testosterone. So observation, there will be keratin plugging of hair shaft and the propionum bacteria will grow inside there. So meaning that there will be superimposed infection by this bacteria. So other direct infections of the skin, they can be bacterial, sometimes causing abscesses, fungal, worms, these are parasites, and viral, such as smallpox. I know smallpox, it does no longer exist, but you never know, it may reappear. It was caused by a virus. Ni indwara imwe mu ndwara zishe abantu benshi cyane, and harimo ababa bakomeye n'aboroheje and so on. It is said that in Europe, I think in 2 or 3 decades, it has killed abami bari bari ku ngoma batanu in Europe. It has killed millions and millions of people. But because of the development of the vaccine yatangiye hambere byatumye indwara icika, and the WHO cyangwa OMS declared that this disease has been eradicated. The declaration was issued in December 1979. So this disease does no longer exist. Ariko, you never know, it may reappear. So you have to know that it was a disease that killed many people. So gram-positive bacteria can cause these problems. Abona uyu muntu wenda ni ku bwanwa, nyamara anagira amaheri mu bwanwa n'ibisebe and so on. But not only them, the females also can develop the same cellulitis caused by bacteria. So you see how this person is looking like. So ntabwo wamenya ko ari umuntu, and this even nowadays there are people who get such diseases. Mu Kinyarwanda muzasanga haba ni amahumane yanyuze ahantu yarenze abantu biyuhagiriye amahumane and so on, bikazaza bavuga. So, but as a scientist, you must see, look if this is not caused by bacteria or a viral infection. So, blistering conditions, I think it is like another section of the presentation. So, better we discuss it after the break. So, if you have a question, you can ask it. Otherwise, we will close and come back at 2 p.m. Any question? So otherwise, we will resume on this part, blistering conditions, where we discuss Pemphigus Vulgaris and the other blistering conditions. I hope you can see the screen and hear me. We were about to start this blistering conditions. I had explained a little bit about it. Blistering lesions of the skin happen when there is, for example, destruction of desmosomes or hemidesmosomes or any other proteins that anchor one cell to another. So as you can see on this low right microscopic image, this is the dermis and the basilar layer is on this side, and you can see that there is a vesicle, let's say a vesicle here, which is filled with fluid within the epidermis. So this is a blister, and clinically it will be manifested as a large vesicles filled with fluid. And clinically on the left side you have what happens. You see that in some areas the epidermis is being detached completely and removed from the body. In other areas it is blackish because it is no longer, the cells are no longer receiving their nutrients. You know that the epidermis is not vascularized, So the cells get the nutrients by diffusion from the dermis. So once there's this detachment, of course, the cells above here will not receive their nutrients as required. So it is said that there are antibodies against skin and basement membrane. Therefore, there is acantholysis, and it happens especially above the basal layer. So supra-basal cleft is seen here, as I was explaining. So there will be blisters with sloughing of the skin, especially on the pressure points. For example, on the buttocks, on the knees, and so on. So they are the most affected areas. So when you do immuno fluorescence, there will be here antibodies where it is more yellow, it is positive. There are positive antibodies against the basement membrane and against the desmosomes, like here between one cell and another. So which explains what is happening. And here it is very important to precise the position of the cleft. For example, here, the cleft is below the cornea, stratum corneum here. You see that between it and the granular layer and then stratum germinativum, there is a cleft here filled with some materials. Some are the dying cells. So this is a subcorneal because it is just below the corneal layer. So this happens in a disease called impetigo. If it is a suprabasilar, like what I was explaining in the previous slides, the cleft is above the stratum basale. This happens in a disease called Pemphigus Vulgaris. The lesion can be subepidermal or basilar, meaning that it is between the epidermis and the dermis, maybe above the basement membrane. So here we have two diseases. We have bullous pemphigoid and the dermatitis herpetiformis. And you see that even clinically they will appear differently, these different diseases, and on microscopy will give a final diagnosis. And of course, the treatment will be depending on the real diagnosis. So as we said, the bullous pemphigoid, here we have a subepidermal or basilar cleft. In the Pemphigus vulgaris, as we saw in the previous slide, we have a suprabasilar here above the stratum basale, and in impetigo we have a cleft just below the stratum corneum. So this is the bullous pemphigoid. You see that clinically it is quite different from what we saw Pemphigus vulgaris that we saw in the previous slides. You see bulla, which are filled with fluid, some are whitish. It is as if they contain pus, others are reddish. So here the problem is that there is a lesion against hemidesmosomes. You remember in histology that hemidesmosomes, they attach the basilar layer to the basement membrane, while the true desmosomes, they attach one epithelial cell to another epithelial cell. So the hemidesmosomes, as I was saying, anchor epidermis to the basement membrane. If they are destroyed, then the epidermis will be detached from its basement membrane. And here we have a true picture, a true histological microphotograph. Here we see a cleft here, which is between the epidermis and the dermis. So if you want to know that the basement membrane is below or above the cleft, you will do a special stain such as periodic acid shift to ensure the location of the basement membrane. But of course, in this case, because it will be destroyed, you will not see much the hemidesmosomes. So the epidermis itself is intact, and there is detachment of the epidermis from the dermis, and in the dermis you have some inflammatory cells. So if you do immunofluorescence, again, as I said, the yellowish staining is the positive of the lesion. So it means there are antibodies here against the hemidesmosome which attach the epidermis to the basement membrane around here. So the antibody staining is along the basement membrane, and these antibodies which were targeted were the antibodies against hemidesmosomes. So epidermis rifts of the basement membrane. And in some areas, here you can see that the antibodies are not seen, but it doesn't mean here it is intact. Maybe the staining it didn't take place. Here we have the empty space on the cleft. And for the dermatitis herpetiformis, as we said, here we have a problem, the problem microabscesses in the dermal papilla. So the problem it is within the dermis proper, as we remember here. That subepidermal or bacillus can be bullous pemphigoid or dermatitis herpetiformis. So bullous pemphigoid, as we saw, is above the basement membrane, while the dermatitis herpetiformis, the region is really within the dermis itself. That means below the basement membrane. So here we have epidermis, and we have this empty area. We have some inflammatory cells just below the epidermis. So as I said, it will not be easy to know where the basement membrane is, if it is here or it is just here. But if you can see very well here, you see that there is nothing as a pink membrane here. So meaning that most likely the basement membrane is above here. And also clinically, you see here that the dermatitis herpetiformis, clinically, it doesn't look like the previous pemphigoid, the bullous pemphigoid. So it is not caused by the virus, herpes virus. The issue is how the lesions appear. They appear as the lesions which are seen when someone is infected by herpes simplex virus. So this was about the blisters, blistering lesions, pemphigoid lesions, as we saw. If you have any question, you can ask it. Otherwise, we go to the specific infections that affect the skin. Okay, it seems there's no question. So the most dangerous cancer, primary infection of the skin is the leprosy. So for those who read the Bible, you know how the leprosy was a big issue in Near East or in Israel and around the countries such as Syria and others. So, and you saw, for those who follow information, you saw that last week the Minister of Health declared that Rwanda has eradicated some what we call neglected tropical diseases, among them leprosy, and there are others they declared that they are eradicated. Okay, the reality is another thing according to our experience, but it is what they say. So leprosy, it is also called the Hansen's disease. So Hansen is someone who discovered the bacteria causing leprosy. The bacteria called Mycobacterium leprosy, Mycobacterium leprae. Okay, so it is written here. So some they call it also Hansen bacilli or bacilli of Hansen. So, and you know, also there are bacilli of Koch causing necrosis and so on. So there are many forms. many clinical forms of leprosy. There is what we call tuberculoid, there is lepromatous, there is indeterminate and histoid forms. So we shall see the differences. Some of them, the big, what you have at least to know is to distinguish lepromatous from tuberculoid leprosy. So one of them has many bacilli, therefore it forms like large nodules. Another one is it has less bacilli. And of course, it depends on the strength of the immunity of the person. As you learned in inflammation, in general pathology, you saw that there is what we call multibacillary granuloma. In case a person is having immunosuppression, they tend to be having many bacilli if they are infected by tuberculosis or leprosy. Or if they are immunocompetent, they tend to have fewer bacilli and therefore lesser reaction with few granulomas. Sorry, few granulomas happen when immunity is compromised, and the more granulomas happen when the immunity is strong. So it is a very serious mutilating and stigmatizing disease. So mutilating, it means it disfigures some parts of the body, or even some parts may be lost. Stigmatizing, someone with that disfigurement of the face, for example, will be constrained to stigmatize himself or herself. And as I said, when you read the Bible, so you know that somebody who was infected by leprosy had to be stigmatized. So you're going to go have a kato. Early diagnosis and therapy are the best options for controlling this disease. Early diagnosis before it may cause disfigurement of the body, and also before the disease may be spread to other individuals. So the serious issue with leprosy is that it is not known how it is transmitted. So it is said to be transmitted by contact, but there are someone not making noise on that. Can you mute yourself? Okay, so I was saying that leprosy is thought to be transmitted by contact, for example, skin contact or contact by body fluids such as saliva and so on. But there are some scenarios which may contradict this. For example, he said that sometimes you see a patient who has leprosy, but his or her partner not having leprosy, while they stay in the same house, on the same bed, and so on. So there are still many issues, and nobody knows the time that elapses between the infection and the occurrence of the signs of and symptoms of this disease. So therefore, it is not easy to control this disease, meaning to limit its spread, except early diagnosis and treatment. It is highly effective, but has a low pathogenicity and a low virulence with a long incubation period. So incubation period, it means from the time a person is infected to the time the disease is manifested clinically. This is what we call incubation period. So it affects skin, nasal mucosa, and the peripheral nerves. So it is most prevalent in tropical countries, meaning that in northern or southern parts of the world, Europe, Northern America, Australia, this disease is rare. In India has 2/3 of all the cases of leprosy worldwide. So meaning that if there are let's say 3 million worldwide of leprous people, 2 million will be from India. So it is therefore mostly in Southeast Asia and in Central Africa, Central and Southern America. So you see that there are countries where we have blacks mainly, and maybe Southeast Asia, but they also have blacks in India and some other countries. The worldwide distribution is also happening due to travel and migration, but this disease is quite endemic in the tropics. So this is what the books say, but politically, some countries claim to have eradicated this disease, including our country. So incubation period, as I said, is not known. Some may think it is 5 years, but it is very difficult to know. So you just find someone is having leprosy, but to know when he or she got this, the bacteria is not known, or is it to know. So some of they think that there may be a genetic predisposition, because you can see that maybe siblings who don't live together, they tend to have to be affected by this disease as compared to the other population around them. And as I said, a transmission is not well known, but people, they think when you are exposed to someone who is positive for a long time, so prolonged and or close contact, this may increase the risk to be infected. And as I said, there is low incidence of conjugal leprosy, meaning that one partner is infected, another one is not infected, while they live together in the same bed. So the port of entry is not known. Some they think it is skin, others upper respiratory tract probable site, such as transmission through droplets, like other respiratory infections, including coronavirus. But this is not well known. These are just hypotheses. So concurrent infection with Mycobacterium tuberculosis is rare. So both of these bacteria, they are a Mycobacteria. So one is tuberculosis, another one is lepre, but it is very rare to see one person infected by both. So clinical classification, as I said, there is a spectrum of clinical characteristics which correlate with histopathological changes and the immunological status, where I said if immunity is strong, the person will have less bacteria and less reaction. If the the immunology or immune system for the person is weak, then he will have many bacteria and larger lesions. So there is what they call Ridley-Joplin classification. So classification proposed by these two people. So they do have a tuberculoid leprosy, that it is abbreviated TT, means tuberculoid leprosy. We will have also repromatous leprosy, and we will have a combination, tuberculoid repromatous or repromatous tuberculoid borderline, and so on. So this is at one end of the spectrum. Here in tuberculoid leprosy, there are a few organisms. So this is bacillary leprosy. They have a few lesions on the skin or the mucosa. One of several sharply defined reddish brown anesthetic plaques may be enlarged. Maybe they can have enlarged nerve entering and leaving the plaque. So icyo mugomba kumenya nuko ahantu hose hafashwe na leprosy, nerve ititakaza akamaro kayo, kubera ko ikintu gishobora kugutema ntubimenye, ushobora igice cy'umubiri cyawe gutwikwa cyangwa kikanavanwaho ntubimenye, kubera ko nerves zidakora ntabwo umuntu ariwe. That's why here they say anesthetic. And then the issues with and so I was disturbed. Someone was disturbing the phone, which is giving internet to my computer. So I hope you can hear me.
Yes.
Okay, so I was saying that in
Yes.
there are a few organisms, therefore this is a postbacillary leprosy. Niyo mpamvu uzasanga abantu bafite utureziyo dukeya ku mubiri kandi n'utwo tureziyo ntabwo biba ibintu bibyimbye, ahubwo usanga ari just a plaque. It looks like a plaque, meaning it is not just a macule, as we say. There is a discoloration, but also there is a lesion which is raised above the surface of the normal skin, but it has a flat surface. ariyo a sensation. Now movement, motor function of the muscles will be also lost. Azaba ameze nkaho ikirenge kidashobora gufata, so on. So in this case also there are some autoantibodies, and this means that these people, they have autoimmune response, antibodies against their own components. And this explains the high incidence of vitiligo. Vitiligo wenda dushaka kutaza kwivugaho cyane. Vitiligo ni indwara irangwa no kuba umuntu yatakaje melanocyte. So iyo umuntu atakaje melanocytes agira vitiligo. Muzabona hari abantu mbona hano mu Rwanda babona wari usanzwe ari normal, nuko nabivuga, ni mugasanga kanye kuzana ibibara cyane mu maso, ku munwa, ugasanga hatukuye kandi bigakomeza byiyongera. Ibintu by'ibibara bitukura bigaragaza ko atagifite melanin. So ikibazo rero ko ntabwo ari melanin gusa, ahubwo baba melanocytes zabo ziba zishwe na autoantibodies. So there will be autoantibodies which target melanocytes and kill them. And you know melanocytes are the ones producing the melanin. So that's why they will have this discoloration. So you see the difference now here. Leprosy, you have many nodules around the skin, and there are quite many everywhere, as you see here, on the trunk, on the shoulder, and the upper limb. And here on the right side, there is a nodule here above the elbow, and here on the buttock. So it is a nodule, it is not a plaque. It is like a tumor. So harabuza asanga afite uruhu rumeze nk'urw'ingwe kubera amabara menshi. And here you see that it has started to destroy the ear of this person. So here we have many granulomas here, inside and here. So again, we have many foamy macrophages containing acid-fast bacilli. So acid-fast bacilli, they can be those of tuberculosis or those of leprosy. And you have seen this in the microbiology that there are different types of tests to do if you want to know if there is a leprosy or tuberculosis. Among them, we have Zell-Nielsen staining. Ikunda gukoreshwa muri tuberculosis. Ariko iyo uyikoreye staining, hari ahantu ugera ugakoresha umuriro utwika lame cyangwa se specimen ufite. Ariko muri leprosy ho iyo step ntabwo iba yo gutwika. So niyo mpamvu bayita cold Zell-Nielsen staining. Nuko bagira abantu batashyushye. Otherwise, they are of the same family because also, as you know, they are Mycobacterium. So other tests we do for tuberculosis, such as oramine stain and Naginex, but which is a genetic test, they don't apply directly to leprosy. So we have a borderline tuberculoid, borderline, and the borderline Lepromatous leprosy. So as you understand, they are in between TT or tuberculoid, and the Lepromatous. So polar forms, TT or LL, are most stable. Meaning, to say stable, it means someone with them tends to remain there, not to change towards borderline. While those with borderline, they change usually toward another subtype. So borderline, this person, he will have plaques, and in some areas he has nodules. Nodules which are Lepromatous, while honor plaques will be for tuberculoid. Again, many images here. And here there is a thickened peripheral nerve in the neck. You can see it here with the extension of the neck. It can be seen. So it is not a vessel or a muscle here. It was a nerve. And usually when you palpate, you feel it that it is hard on the palpation or firm and some lesions around here will be anesthetic, so the person will not feel that you are touching him or her. So this was a 35-year-old male. The biopsy from the fecal and the ulnar nerve of a vitaminase male was made. So urinary biopsy, it is not the case presented here, of course, because this is made. So here there is someone who has leprosy on the lower limb. Okay, I hope you can hear me. So I was explaining that this person had a leprosy, nerve yabaye affected, therefore innervated parts were no longer the parts which were innervated by this nerve were no longer having sensation. Ibyo bituma akenshi iyo habaye traumatized ntabimenya, akandagiye mu cyuma ntabimenya cyangwa mu muriro and so on. But also on the other hand, you know that iyo innervation yani itakaye hari tendency ko haba affected na vascularization itaba optimal, ibyo byose bishobora gutuma hasa wounds such as this one. So this is they have seen this is the feet where the feet is staining. It is the same as called Ziri-Nielsen stain. Utuntu mubonamo hano dutukura turi covered cyangwa tutari covered nk'utumeze nk'uturongo duto cyane. These are bacilli. This is how they appear on the microscopy. Zaba iza leprosy zaba iza tuberculosis. Uzazitandukanya gusa bikurikije stain wakoze, otherwise they appear the same. So hariko mubona duke, otherwise hano harimo nyinshi hano zirunze zitukura nyinshi, izi nizo ziyahirunze. So bisana ko uyu muntu afite lepromatous kuko afite a lot of bacilli. So the differential diagnosis in here is leishmaniasis, which affects also the skin. I think this is a dangerous disease, a parasitic disease. Ntabwo nzi niyo mu Rwanda zihari, ntabwo ndabona, ariko I saw cases in Addis Ababa in Ethiopia. Iyo ubonye ngira ngo ni cancer bisa na umurwayi ameze nabi cyane mu maso, ntumenya ko akiri umuntu, the way it appears. Others are atypical mycobacterial infection. You know that mycobacteria, the typical one have tuberculosis and leprosy, ariko ari tugira bita atypical. Akenshi no kuzivura biragoye. And you cause a gene expert, which is a genetic testing, optimal, recommended by WHO, is ntabwo zifata atypical mycobacteria kubera ko hazamo kit izana na machine yo gupima leprosy cyangwa tuberculosis. Ntabwo reagents zirimo zishobora they can't detect atypical mycobacteria. So it is quite a challenging condition when a patient is having this. Mpuzasanga tuberculosis yarangiza imiti y'amezi 6 bagasanga ntacyo yakoze, bakongera bakamutangiza rimwe na rimwe bakamushyira kuri injectable zimara igihe kinini, ariko byose n'ibyo bitanga, because these are difficult disease the bacteria to treat. Other differential diagnosis, of course, are tuberculosis and rhinoscleroma. Rhinoscleroma ni ikunda gufata mu mazuru, mu kanwa, palate, and so on. It is caused by some bacteria, but which are not mycobacteria. The dermatofibrosarcoma protuberans, this is a tumor which is it is intermediate between cancer and benign. And even yesterday we had a case of wayibazwe hanyuma after months it recurred. Another differential diagnosis is benign fibrous histiocytoma, which also is a disease of the dermis. So that's all for leprosy. It is the only infection we have taken. Otherwise, other infections, they affect different parts of the body, and you will learn them from other presentations. Next question. Okay, so changes in pigmentation. So vitiligo nayo nayivuze, urabona uyu muntu yari umwirabura maybe, ariko hari ibice bimwe na bimwe byatangiye. Okay, niba ari umuzungu hari ibice bimwe byatangiye kugira indi couleur, niba ari umwirabura hari ibice, noneho ibice byinshi byabaye nk'iby'umuzungu. So the problem here, these people, they have antibodies destroying melanocytes. Ngira ngo mugomba gutandukanya vitiligo na albinism. Albinism baba bafite melanocytes ariko nta melanin. Naho vitiligo baba ni melanocytes zicwa, noneho therefore abura byombi ari melanocytes ari na melanin ku bice biri affected. Albinism ifata umubiri wose, ariko vitiligo ifata uduce duke. So that is vitiligo. Kugeza ubu nta muti igira. I had one of my teachers when I was doing specialization. He had vitiligo. If there could be a treatment available for that, he could have taken it, but it doesn't exist. So there are some drugs which are in clinical trials. They are trying to see if they can treat this. Until now, no effective treatment is yet there. So proliferative melanocytic lesions, we have nevi. So nevus, it is one when there are many, it is nevi or nevi. This is when you have a proliferation of melanocytes, but if the cells are benign. When they are malignant, now it will be called melanoma. So some people, they are born with nevi. Others, they develop them during their growth. So there are dysplastic nevi and then malignant melanoma or just melanoma. So nevus or emor is the benign proliferation of young melanocytes. Where are the nervous cells? They can be seen in epidermis, in dermis, or compound, meaning in both at the same time, cells in dermis and in epidermis. So there are many types of nevus. There's one called the speech nevus. It is seen in young people. It looks aggressive, but histologically it doesn't. So when I call it in cancer, but it doesn't kill, and histologically there are no malignant cells. There is the haro nevus one undergoing regression. So harige nevus isa n'ishonga wasangamo hagati yashizemo isigaye kuri periphery. That's why it's called the haro nevus. So dermal nevus, here we have an example. And on the right side we have a microscopy. So we have a proliferation of melanocytes. So the more reddish cells here are keratinocytes or epithelial cells with keratin content maybe, and these more light cells, these are the melanocytes which are proliferating and are going down into the dermis. So here there is another nevus, here a bigger one, nevus are on the chest. This is a breast. So a large nevi here, and you see this one, this exists, and I think I saw such a case in Dar es Salaam. It was covering the back and the buttocks. So this plastic nervi, they are still benign, but they have some cells which appear abnormal, and if not treated, usually it progresses to melanoma. And they say it is part of a familial syndrome, maybe because, as you know, you saw in carcinogenesis, there are some syndromes which predispose some family members to have certain cancers or tumors. So melanoma, ngira ngo mwarabibonye muri general pathology, carcinogenesis or neoplasia. In nomenclature, you have seen how the names of the tumors are given, and you saw to call misnomer, meaning that the name which is given it doesn't reflect the reality of the disease itself. So melanoma per se, if you follow just the regulations, you could understand it as a benign tumor from melanocyte, but it is not. It is a cancer. So it is a very unpredictable tumor. Iyi cancer ni cancer mbitane kubera ko ushobora kuvura umuntu ukayibaga, margin is negative, umuntu akabaho ngaho uzi ko yakize n'imiti yayihawe ntagaragaza ikibazo na kimwe. Nyuma y'imyaka 15 cyangwa 20 ugasanga metastase yindi wakuyeho kera irahari. Bivuga ko hari ahantu selile zagiye zikihisha, noneho hashiyo myaka yose zikongera zikabyara izindi kansa ikongera ikagaragara. So that's why they say it is unpredictable. Ntababanga kandi gato nta kibazo gatwaye. I think I mentioned that the Robbins, who wrote the books we use in teaching or in running pathology, he was killed by melanoma from the eye, from the uveal tract. So nuko icyo nshaka kuvuga nuko ari umuntu usobanukiwe ashobora kuvurwa easily, but melanoma ashobora gukora akantu gato cyane 1 millimeter kakagaragara gutya, ariko already karagize metastasis nubwo bagakuraho umuntu ntibimubuze gupfa. So genetics here, we cannot say that there is a familial predisposition to this, except as we saw on the previous slide, if the family is having a familial syndrome predisposing to a set of tumors, including nervous and melanomas. So the big issue is the exposure to the ultraviolet light, including the sunlight. So that's why you are always advised, or you have to advise your clients to make sure they are not exposed unnecessarily to the sun. There is the ethnic direction, and also maybe this is because nubwo iboneka no mu birabura melanoma, but it is seen more like more in whites, probably because the melanin doesn't protect them. Nubwo baba ahantu haba izuba rikeya, but they tend to have more risk to have melanoma than in blacks. So noneho abazungu baba mu bihugu biba mu izuba ryinshi nka Australia, they have so many. So radial growth is followed by penetrating phase. So icyo bisaba nuko iyo itangira ikura ikurikije junction between epidermis and dermis, they spread horizontally. Ariko itinze noneho itangira kumanuka muri dermis, penetrating, destroying the dermis, the hypodermis, muscles, bones, and so on. So metastasis, as I said, it happens even when the tumor is still very small, and it is persistent. Ibyo nabivuzeho kare kubera ko usanga hari nk'umuntu ugaragaye ko afite metastase inyuma y'imyaka 15 tumor ya mbere barayikuye. So what are the risk factors for cutaneous melanoma? So the factors of high risk are listed here. No kuvuga izongera inshuro 50 risk yo kugira cancer iyi melanoma ugereranije n'abandi bantu. The first of all is persistently changing more. Umuntu ufite nervous ugasanga uko ari meze none mu mezi ataha yahinduye kara, yahinduye texture, cyangwa se yahinduye its borders, how they look the light. This is very dangerous. Of course, adulthood, abantu bakuru ni bakunze kwegera abana, ntabwo ari kenshi keretse bariya ba albinos. Clinically, atypical moles in a patient with 2 family members with melanoma. Ibi bivuga ko niba mu muryango w'umuntu runaka harimo abantu 2 bagize melanoma, akaba no afite nevus, uwo bafite ibyago byinshi nawe ko azagera melanoma. So therefore, when you talk to the patients or to the population, you must know the information you give them. So umuntu naza afite mole, n'uwo yabaje kwivuza ibindi bintu byayo byose akaza afite nevus, ukamubaza ariko nta muntu wanyoyezgira kanseri y'uruhu, akavuga ngo yego. So now you know what to advise him or her. Intermediate risk, if there is an increased risk of tenfold. So first, if there is a family history of melanoma, just one case, ariko umuntu wenda akaba adafite, uretse uwagize melanoma abasigaye akaba nta wo ureba akaba adafite nevus, so risk zaba ari 10 gusa, ariko nawe afite nevus risk zaba 50, yongera 50. Congenital nevus, hari abazivukana. Personal history of prior melanoma, niyo umuntu yagize agira melanoma bakayivura igakira, aba afite ibyago byinshi yuko yagira indi melanoma, because in any cancer have limitations. Okay, let's proceed again. So if a person has been treated because of melanoma and is cured or she is cured, he has a risk to develop another melanoma in the future, not necessarily being a metastasis from the previous one. I was saying that the mutation which is seen in almost all cases of melanoma is a KRAS mutation, and one cell or more cells may have it. So if one cell has it and is allowed to multiply, it will cause a tumor. If that tumor is removed, while there is another cell which has already that mutation, it may also proceed to develop another cancer. So xeroderma pigmentosum, I said that this is a condition whereby people, they are more prone to have mutations due to exposure to ultraviolet light. So abantu basically ntabwo baba bafite uburyo bwo gukosora amakosa yaje mu ruhu muri gene zo mu ruhu kubera ultraviolet light. Ubusanzwe iyo tugize twa exposed to the kuzuba n'urugero, melanine iraduprotege, ariko niyo bibayeho ko melanine rushwa ingufu na ultraviolet light, hakaza ama gene mutations, haizo bita pyrimidine dimers, umubiri wacu ufite system yo gukuraho iryo kosa. So when now that repair mechanism is no longer possible or is impaired, the person will be said to have xeroderma pigmentosum syndrome. So it's not a disease itself, but it is a syndrome predisposing him to have severe diseases such as cancers. So risk za after zo kuya cancer ni kimwe na albinos. ngira ngo abarwayi nk'aba barahari no mu Rwanda barahari n'ahandi barahari. Ibibazo byabo babihuje n'aba albinos. Unfortunately, wenda nahoze ngana n'umudermatologist wacu tuganira ku kibazo cy'aba bantu, arambwira ati hari mu Rwanda barahari benshi abafite dermatopathology, abenshi aba ari abana kuko n'ubundi ntibakura. Abenshi ntibakura n'ubundi bakiri bato, ariko hari uburyo bwo kubarinda, harimo amavuta barinda imirasire y'izuba, kubangiza n'ibindi. Kugira ngo ibyo byose babibone, leta ubu ibikoresho byo kubafasha birahari, ariko kubabona biragorana kubera ko famiye zabo ntiziba zishaka kubagaragaza. So the dermatologist was telling me they tried to sensitize the albinos people to allow these children with xeroderma pigmentosa to be in their associations, kugira ngo bajye bashaka kubona ibyo bibafasha, ariko abarubinos barabyanze ntibabishaka. So it is a very big issue, but the best way to take care of these children ni uko bajya ahantu hamwe nko mu bigo, hanyuma bakajya, niba ari ukwiga bakigira ahantu barindwa izuba n'ibindi bintu, niba ari imiti bahabwa yo kwisiga ukamenya ko bayisize and so on. Ibyo nicyo gishobora kubafasha, and we want to do it if we will be able to do so. Kubera ko ngira ngo ubwo kubagezaho ibikoresho byari binaniranye, leta yagerageje kohereza ibyo bikoresho mu turere, ariko uturere tumwe ntacyo tubikoraho, ntacyo bababwiye, barayibika cyangwa I don't know. So it is a very big issue, but I think we will work on protecting them. So the xeroderma pigmentosum, ikibaranga ni kiro batinya izuba bo ubwabo, usibye no kuba uruhu rwabo ruzitinya, n'amaso arabitinya ku buryo ntashobora kureba ahantu hari urumuri rwinshi, hari urumuri rw'izuba ahita asa n'uhumye. Ikindi ko uruhu rwabo rutihanganira izuba, usanga rwaratangiye gutendera nk'urw'abasaza cyangwa abakecuru. So elasticity is lost, nicyo kibaranga. Clinically ushobora kumubona ugahita ubibona ari umwana ukabona afite uruhu rw'abasaza. So there are other problems. Abafite vitiligo birumvikana baba batakaje melanocyte with their melanin, therefore the affected area may be easily affected by the melanoma. Abantu bajya kuzuba, frequent sunburns. So 5 to 10% of the cases they are familial, possibly harimo na mutation, harimo abafite neurofibromatosis 1 mutation, nayo ishobora kuba yari predisposing factor to melanoma. White ethnicity, I have mentioned it before. So low risk factors are immunosuppression, sun sensitivity, or excess exposure to the sun. So melanoma history, what happens? Here in A, we can say that we have a normal skin. This is a drawing, of course. This is epidermis and the dermis with vessels. These are fibers. So as you know, melanocytes, they are located on the basilar surface. Ariko ntabwo zihari zonyine, ahubwo ziba ari kamwe ugereranyije na squamous epithelial cells nyinshi. So the next step is to have a proliferation of the melanocytes, as you see. Here now they have replaced almost all the epithelial cells. No epithelial cells are seen in the lower parts. And this is still nevus. Nevus, which is still within the epidermis. Here it is a compound because it affects both epidermis and the dermis. And here we see that there are some cells with very large nuclei. So meaning you have started to have atypical cells, atypical melanocytes. This means there is atypical nevus. Then, if these atypical cells proliferate all over the dermis, the epidermis, the dermis, then this is the melanoma. And you can see clearly here that the tumor has gone to the here the tumor has gone in cells, they have gone into a vessel. So if they have gone into a vessel, it means metastasis is already taking place, because a blood vessel or a lymphatic vessel will bring cells to this kind of organ. So clinically, kubera ko melanoma ibigizwe na melanocytes which produce a lot of melanin, usasanga kenshi ari umurwayi ufite ikibyimba gisa n'umukara neza neza nk'uko amakaraso. Hari abiba biri brown ariko byinshi bari umukara. So on histology we have these clear cells here, and here we have cells with pigment, brown pigment here. Ahanganaho on the lower right side we have cells, this one, but here below we have some cells which are filled with a black or brown pigment, which is melanin. So this is how we diagnose melanoma, and we precise. There are other factors we precise, prognostic factors. Iyo dusanze afite less lymphocyte infiltration, nuko ko immune system ibiri weak. Therefore, that is a factor to poor prognosis, and there are other things to look for. So you see here a blackish lesion. Umuntu no ko afite nerve, ko turabona utundi tuntu turi utunodire turi utumukara handi hano, but this is destroying, as you see. If the crater mo hagati, here we have another one. Here we have it on the sole or the foot. So the four major subtypes, they are acrolentigenous. Acro now is a carinic, anything related to the extremities, fingers, hands, foot, toes. It will be called acrolentigenous. Harinio vita maligna, yes.
I want to know the difference between ikibibi and melanoma.
Sorry?
Icyo bita ikibibi mu Kinyarwanda na melanoma bitandukanira.
Kuri wowe surabona bihuriye?
Je nabonye melanoma ari ahantu hasa n'ahirabura cyane, nagenda n'ikibibi cyabaho by as a result of melanoma.
Do you mean anything which is black or having another color will be melanoma? Okay, tell us what are the characteristics of melanoma, because I said them. How will it be the region of melanoma? Okay, so the subtypes they have a nodular melanoma, and this is when it is advanced, and this destroys surrounding tissues in most of the cases, and some others are called superficial spreading, meaning they are just inside the dermis. So, and we will understand that this will be diagnosed on histology. Nodular, it can be seen even clinically that it is nodular, and histology will confirm it if it penetrates inside here within the dermis and even beyond the dermis. While acrolentigenous, it can be even nodular, but when it is located on the extremities, it will be still called acrolentigenous. So I have mentioned this ocular melanoma, and I mentioned it even the last time, because we have a melanocytes within the uveal tract. Uveal tract, you know, it is the area where there is we have an iris just closer to the lens. There are melanocytes there. So from them, we can have a melanoma. We can also have it from the retina, because there we have embryonal cells. And usually ocular melanoma will metastasize to the liver. Nobody knows why, but this is an observation. Most of these people, they have metastasis on their liver. And the ocular melanoma has a poorer prognosis as compared to the skin. And I was working in a group in Sweden where they are still trying to develop some drugs or modes of treatment to treat ocular melanoma. It is still cumbersome. They have many cases of ocular melanoma, and they die very early, around after 2 years, almost, or the patient died. While for the skin melanoma, they can survive longer, and some are completely cured. So this is a serious disease. And I would mention also that the very first case we received at Africa when pathology department started in 2013, the first case we received was ocular melanoma. So clinical manifestation, the survival of this patient overall, it is meaning within 5 years, 60% of this patient will be still alive, but this is variable. There are many factors. So the prognostic factors, poor prognostic factors, we have breaststroke. So these are things we do in histology. When we have a case of a melanoma, we do paper thickness from the surface to the deeper area where the cancer cells arrive. So we say the breaststroke level was maybe 5 millimeters, 10 millimeters, 20 millimeters, and so on. Clark level uyu breaststroke ni umuntu washyizeho ibyo Clark nawe n'undi muntu we yaravuze ngo melanoma muzajya mustage aho igeze mukurikije iki, niba iri muri epidermis gusa iyo ni Clark level 1, niba iri muri Epidermis Clark level 2, niba iri muri mid-dermis Clark level 3, niba iri muri lower dermis ni Clark level 4, niba yageze muri hypodermis and the muscles and so on, in Clark level 5. Birumvikana when or with an advanced disease, the prognosis will be poor. So ibingi nabyo bifasha mu gukora staging, TNM, tumor and lymph node. Because if a patient is having metastasis, of course, the prognosis will be poorer than a patient without metastasis. Also, it was seen that when we have two patients with the same stage, a male one will have a poorer prognosis as compared to the female. That is an observation which is not yet explained. So there is what we call sentinel node. Sentinel node, this is a procedure that helps to predict if a person has already a metastasis or not. So if a person is having, for example, a cancer on the a melanoma, let's say melanoma on the finger, icyo bakora bamutera umuti muri vein ituruka hane hari ya tumor. Uwo muti akenshi bari umuhondo, niyo mpamvu na hano nakari blue, hano shani ari blue. Uwo muti uragenda birumvikana ugenda okay, that was a vein, not necessarily vein, in just a soft tissues there. Uzagenda, it will be then through lymphatics, and when it arrives to a lymph node, cyo bazakora niki, bazareba lymph node ya mbere uwo muti wagezemo. Icyo bisa nuko iyo lymph node niba na metastasis ariko igomba kunyura, iyo lymph node niyo ya mbere yagombye kuba selile zaranyuzemo. Iyo lymph node barayifata bakayikuramo, then you do as a biopsy, you process, iyo usanze wa muti urimo ugasanga nta malignant cell, metastatic cell zirimo, then you confirm that uyu muntu nta metastasis yari yagira. Ariko iyo usanze zirimo, therefore it means probably this person has already metastasis distant organs. So this is what is done. Ntabwo ari melanoma gusa bikorwamo na breast, kubikora kuri breast, bakaba bati uyu muti muteye muri breast, noneho mukareba muri axillary lymph node. Niba lymph node ya mbere umuti wagezemo mukareba niba irimo cancer cells, byadufasha kumenya niba umurwayi afite risk ko afite distant metastasis, therefore bakamuvura accordingly. But it is not yet implemented in our country. So that's all for melanoma. Any question? Okay, the epithelial tumors, we have what we call seborrheic keratosis. Is not a true tumor. There are just changes within the someone who is making a noise. Can you be considerate in the discipline? It's too much. So this is in older people. So on, and on histology, we see that it is rich just in the keratin. It is benign. There is a epithelial proliferation, as you see here, and we have a keratin inside, but there are no atypical cells. So this is just a benign condition. There is also actinic keratosis. Iterwa no kuba umuntu aba exposed ku zuba, and of course this is a predisposing factor to squamous cell carcinoma of the skin. So usanga hari ahantu uruhu rwangiritse, and when you do histology you find that epithelial cells in the epidermis are some are becoming atypical, and in the dermis you can see that they fragmented with solar keratosis. So keratoacanthoma. So acanthosis, we saw that is proliferation of epithelial cells. Kerato meaning the formation of keratin. So it is a mass combining proliferation of epithelial cells and accumulation. So we may have atypia, meaning that there is some atypical cells. So if you measure that's why they say cup or crater shaped. Can I tell you according to experience who is making a noise? So basal cell carcinoma, it is the most common skin malignancy, and it is seen in solar exposed skin. Icyo twavuga kuri kanseri ni uko ni imwe muri kanseri zidapfa kwica keretse umuntu yakoze negligence. Otherwise, it is a cancer which is spread very slowly. It doesn't metastasize, and in most of cancer registries ntabwo bemera kuyandika nka kanseri kubera ko umuntu uyifite yagombye kuyikira if he or she is serious. So ntabwo muri cancer registries zo mu bihugu byinshi ntabwo bayandika nka cancer. But it has atypical cells. So it is usually superficial spreading in large nests which don't infiltrate into vessels, therefore no vascular invasion or metastasis. Another one is squamous cell carcinoma. Dukunda kuyibona mu Rwanda birahari byinshi, and of course it arises from epidermis, especially in areas exposed to the sun. So the causing agent being the ultraviolet light. So the age of incidence is dropping, meaning that mbekera yafataga abantu bakuze ariko biri gufata abantu bakiri bato. Abari abantu bafite xeroderma pigmentosum bakunda kuyigira cyangwa se albinos. So nibuka ko nakoreraga hari albinos benshi na wasanga hari umuntu ufite albinos ufite at the same time squamous cell carcinoma and a basal cell carcinoma. Ugasanga imwe iri ku rutugu, indi iri ku kuboko, and so on, because they are exposed to the sun. Especially abagirwa inama yo kwifuza kwambara neza ariko ntibabikurikize, ugasanga yambara imyenda isiga amaboko cyangwa ibitugu hanze, batamera kwambara ingofero nini zibarinda izuba, and so on. So these ones, they metastasize and kill. And in Rwanda, we see many of them on the limbs, on the legs and the foot. Uzasanga umuntu ufite igisebe kimaze imyaka n'imyaka kidakira, it is a predisposing factor to be transformed into a squamous cell carcinoma. Another factor is sinus or fistula. Hari abana bafite osteomyelitis, no kuvuga mu magufa yabo yaraboze, hakavamo pus ishaka inzira iga create sinus, to create a sinus, and then there will be fistula between the bone and the outside through the skin. So when that fistula is there for a long time, it is a predisposing factor also to develop a squamous cell carcinoma. So they produce the keratin, and for us in pathology, these are the easiest diagnosis to make on histology when it comes to cancer. So usanga abo umuntu uje muri postgraduate ikintu cya mbere agomba kumenya ni ikintu to diagnose squamous cell carcinoma, because it is very simple. For other cancers it is difficult, but squamous cell carcinoma, especially when they are well differentiated, they are very easy to diagnose. So for the dermal tumors, we have a fibroma, meaning it is a benign tumor arising from fibroblasts. You can see here that it is well circumscribed here. The epidermis is above. Hari dermatology of dermatopathology, Grens zone ni zone iri hagati ya tumor na epidermis. So there are some tumors which are known to always leave this Grens zone, intact zone here. So here also we have it. So xanthoma, here we have histiocytes which contain the lipids. Even yesterday we had a case of such a case. So here we have even a giant cell here with multiple nuclei but one cytoplasm. So Kaposi sarcoma, we come back on it. We saw it in the previous presentation. So it is seen especially in patients with HIV. Ariko ibaita epidemic, hakabana n'abandi barwayi badafite HIV ibaita endemic, Kaposi sarcoma. It is caused by human herpes virus 8, HHV8. Nabaita Kaposi sarcoma herpes virus. So it's written here. So as I said in the morning, this is a vascular region because there is a proliferation of vessels here, as you see here. So what happens? We have a bacteria, a virus here. It infects B lymphocytes, and therefore, if it infects B lymphocyte, it will cause body cavity lymphoma. Hariyo bita itera yitwa effusion lymphoma. So akenshi bafite pleural effusion, abangaba usanga harimo many cells. When you look at them, they look malignant, and if you test for HHV8, you find it. So this is one type of disease which can be caused by HHV8. Nukuba ko virus ntabwo itera Kaposi sarcoma gusa, ishobora gutera n'izindi ndwara harimo n'indiya body cavity effusion lymphoma. So when the cells which are affected are mesenchymal cells, for example fibroblasts, they will proliferate, and for them to proliferate also will have proliferation of the vessels, angiogenesis. So therefore this is why Kaposi sarcoma is considered to be a vascular disease, a vascular tumor. So these are neutrophil cells and the red blood cells inside these vessels. So this is how Kaposi sarcoma develops, and so on. So I had mentioned some steps or stages. Iyo ikitangira usanga hari discoloration. Hano nayo iba ari somehow black, but this is not caused by a pigment. As it progresses, urabona zitangiye kuba ibaita patchy stage. It imeze nka macule. When there are plaques, now it is the plaque stage, and the third stage is nodule. So on histology here, you see that in the patchy stage, you have just proliferation of some vessels and some other cells, few cells. Here, on the plaque stage, you have more vessels and more cells, these black ones. And in nodular, we have a nodule with several vessels and abnormal cells. So, and as I said, when it is advanced like this, it will be difficult to treat or to be cured. Ariko n'abantu iyo bahawe imiti ya HIV akenshi barakira niba ari umurwayi ufite HIV AIDS. So someone is adjusting the music. Okay. So this is how clinically it will appear as abafite macule or patchy stage, chance of the plaque if it is in the plaque stage, or nodules. So history will be very important to know if the patient is having HIV/AIDS. It will be very easier to think about the Kaposi. But if the person is not having HIV/AIDS, probably this may be a melanoma or a nevu. So biopsy will be around able to give a final diagnosis. So other diseases, I think this I had mentioned, dermatofibrosarcoma protuberans, which is one of the differential diagnoses of leprosy as we saw. So in it, you also have vascular proliferation. And as I said, it is very frequent. And yesterday also we had such a case which recurred after surgery. So these are nodules, papillonodular thigh lesions. So on the thigh you see these are nodules. So here and the papilla they are smaller than nodules. So on the histology we see what we call storiform pattern or pinwheels pattern. Ausanga the disposition of the cells is like a cell
kuri pisine noneho baba sasa mu wari kwivugira kuri pisine yaho kumenya bebe mu mazi iyo nyoko yawe na neza.
Okay, so if you have a question, you can ask them before I ask mine. Okay, so there is one question here. Maybe the first one I have not mentioned it. Tunia cruralis or joke each region ni indwara abantu bagira bafite fungal infection bakishima cyane ngo iyo bishima babikora hari ababikora mu buryo bumeze nko kujokinga ku buryo wenda utashobora kumenya ko ari ukwishima ugira ngo ari kwikinira. That's why they call it joke itch. So tinea cruris. So otherwise the second option or statement, metastasis from skin Basophilic Carcinoma are very frequently seen up to 60% of cases. Albinous person cannot develop a malignant melanoma. There is a 50-fold decrease in risk of melanoma in the case of persistently changing mole or nevus, and the syndromes predisposing to skin tumors include albinism, xeroderma pigmentosum. So you will choose the best option or statement. You can write in the chat. Okay, so tinea cruris or jock itch is a superficial fungal infection, yes, but it is located in the crural area, so in the inguinal area, not in the scalp. So cruralis refers to something around the inguinal area or genital areas. So therefore, that is false. So metastases from basal cell carcinoma are very rare, as we said, because this cancer is very less aggressive. It is not aggressive. It doesn't infiltrate. It doesn't metastasize. Albinos can not develop malignant melanoma. This is false because albinos, they are among those at high risk of developing melanoma. There is a 50-fold decrease, so this is false. It is increase in risk of melanoma in the case of persistent rechanging more. And syndromes predisposing to skin tumors include albinism, eczema pigmentosum, and so on. So this is the true statement. So the true answer was E. So someone respond correctly to this one. Okay, so the next is matching. You can match also. Tuberculosis leprosy, Lepromatous leprosy, endemic Kaposi sarcoma in a difference to epidemic or African, as I say. And so on. And very aggressive tumor on the such that intermittently exposed to sunlight. How do you call that tumor? And so on. So you can match, you match and you write in the chat.
We are not seeing your slides. Prof, we are not seeing your slide.
So, I hope you can see them now. Okay, so we can give the corrections. So tuberculoid leprosy can be matched with what? Tuberculoid leprosy, we saw that it is postbacillary leprosy. So 1C. Lepromatous leprosy is multibacillary leprosy. So 2 to D. Endemic Kaposi sarcoma is the same as European Kaposi sarcoma, as I mentioned, and the African is epidemic or HIV associated. So a very aggressive tumor on the cells that are intermittently exposed to the sunlight. This is 4 and 5 pigmented tumor on the palm of the hand, sole of the foot, or under the nail. So maybe probably we need to read the question, the whole statements before you answer, because this both refers to melanoma, but which one? So, as I said, the melanoma which appears on the extremities, it is acro-lentiginous. So, 5 will be linked to B, and 4, it is a very aggressive tumor, and this is a nodular melanoma. Because the nodular melanoma is the most aggressive form of melanoma. Any further question? So here, intermediate leprosy and the African Kaposi sarcoma were distractors, so they have nothing to be matched with on this left side. Okay, thank you, and we see each other next week. Tomorrow you will be with Dr. Emil. As for me, we see each other next week. And I think you got these presentations through the emails, but also I hope you have you got the password to access this course online in the Moodle system. Dr. Emil told me that he gave you an access password.